yeah, if you have your own doctor, then obviously you want to ask them the specific questions regarding your own knee. We have two types of cartilage in the knee. We have the cartilage on the end of the bone, which looks like the one on the end of a chicken bone, tread on a tire. When that wears out, that's what arthritis is. And then we also have the meniscus cartilage, two little semicircular shock absorber cartilage in between the femur, the thigh bone, and the tibia, the shin bone. And those two little semicircular meniscus cartilages are very important for actually the health of the fluid of your joint, believe it or not. So that's one of the big things they do. Secondarily, they're also important for stability because the thigh bone's round and the shin bone's flat and they don't really match up real well. So the meniscus cartilages help them match up better and it helps for stability. Now, the meniscus is usually the type of cartilage you hear about, like when an athlete tears the cartilage in their knee and they need to have arthroscopic surgery. It's usually not the cartilage on the end of the bone that quote unquote tears. You can have an injury in sports that injures that, but it's usually the meniscus. So when the meniscus tears, it doesn't have a very good blood supply. Only where it attaches to the casing around the joint, the capsule, does it have a good blood supply. So if it tears in that area and it's a small tear, very small, less than a centimeter, it may heal on its own or with a little help from us with a PRP or bone marrow shots or stem cells or those things. If it's torn in the inner third where there's absolutely no blood supply, it's almost never going to heal. So even if we went in there surgically and sewed it together, which I'm a surgeon as well, and I do a lot of minimally invasive arthroscopic surgery, even if you go in that inner third area where there's no blood supply and you sew it together, it's probably not going to heal. Although we're getting more and more aggressive nowadays with the biologic treatments and the stem cells and the PRP and all that. So it doesn't have a very good blood supply, so it doesn't usually heal well on its own. And that's why it will give you symptoms because now it starts flopping back and forth or it's unstable. So either it starts pulling on that joint capsule or that casing around the joint because it's torn and it gives you pain from that. Or what happened to me, I had that happen to me. It starts flipping in between the two bones and causing your knee to lock or catch because it gets caught or pinched in between. A, that hurts. And B, you feel like your knee's locking up. And sometimes it does lock and you have to kind of shake it free. Or there's rare occasions where it locks and you can't get it unlocked. We have to take the person to the operating room and we have to go in there arthroscopically and try to flip that piece that's torn back over and hopefully repair it. Or if it's not repairable, just trim out the torn part, but leave the rest behind. In the old days, like the 1970s and even the 1980s and before, they would make a big incision, take the whole meniscus out. Oh, you'd feel great for a while, but when you lose your shock absorber, now that cartilage on the end of the bone is going to really wear down a lot faster, and you're going to develop arthritis a lot faster. So we try to preserve it if at all possible, but the symptoms you're going to feel might be pain, clicking, swelling, locking where it gets stuck, tenderness to touch. Any other things you can think of? Because you've obviously seen a bunch of these as well. I mean, any other things? Giving out, meaning buckling, not necessarily, but
Feel like
locking is,
unstable, maybe
yeah.
another
I
thing
mean,
that
if it's catching or locking and it's swollen, it's probably a meniscus tear. It could be something loose floating around too. There's these things called loose bodies. Sometimes a little piece of cartilage, even a piece of meniscus, might break off and start floating around inside your knee. That'll lock your knee up, and that'll sometimes feel like a meniscus tear. But the best thing to do is to get in to see somebody who deals with that. Orthopedic surgeons, especially sports medicine orthopedic surgeons, we deal with that stuff all the time, and that would require, you get an X-ray because there could be a little thing that broke off, and you can see it on the X-ray sometimes. Also, an MRI is going to show that. It's also going to show a meniscus tear, which an X-ray won't show. It's going to show a lot of other things that an X-ray won't show either. So all those things are important. Sometimes even an ultrasound is important because you'll see that loose thing floating around in there. You'll definitely see fluid. You can even see a peripheral or an outer meniscus tear, but you can't see a deep meniscus tear with an ultrasound. So all those things combined, all the pieces of the puzzle, the history, we can usually figure out if it's needs surgery or doesn't need surgery. Because the other thing, we might as well get to this, is that a lot of people maybe in their 50s, 60s, 70s, they just have knee pain and maybe some knee swelling. They're not having any locking or any mechanical symptoms giving way, unstable symptoms, anything like that. It's just pain. And they get an MRI, their primary care orders an MRI, and they get sent to us and it says, I have a meniscus tear and I need surgery. And that there's different types of meniscus tears, just like there's different types of snowflakes. No two snowflake looks the same. No two meniscus tears look the same, but there's general categories. So if you have an unstable piece that's flopping back and forth, yeah, that's going to usually need surgery. But if you have wear and tear, just like the cartilage on the end of the bone wears down, well, the meniscus wears down too. And as it wears down, it kind of degenerates and gets kind of frayed and it can sometimes break off and things like that. But most of the time, it just kind of just starts to wear out and wear and tear. That doesn't always need surgery. That is more of a degenerative tearing as opposed to necessarily a discrete tear. And the good news is there that most of the time that doesn't need surgery, and that's really more of a degenerative process. So that's where the regenerative medicine, the PRP, the bone marrow, the stem cells, all that stuff comes into play. And you asked about PRP earlier. I think I neglected to mention this, but studies have shown there's at least 37 studies at this point, at least, that show peer-reviewed high-level studies that show that PRP is better than cortisone injections. It's better than gel injections. It's a lot of times better than standard physical therapy, and it's better than even arthroscopic surgery for degenerative meniscus tears or for arthritis. So you don't always need surgery when you have a quote unquote meniscus tear on an MRI if you don't have mechanical symptoms, and the research bears that out.